Hi, listeners. It's hard to believe, but New Frontiers in Functional Medicine has been going strong since 2015. With over 200 episodes and over 2 million listens, we are growing every year. My goal is to continue to bring you the best minds in functional medicine, epigenetics, and longevity. I want the content to be actionable for the functional medicine clinician and interesting for the rest of us. Thank you for supporting this podcast with your likes, with your honest reviews, with sharing the episodes with your friends and family. And if you haven't done so, please consider leaving a like or leaving us an honest review wherever you've accessed this podcast. Thank you, thank you, thank you to our sponsors. Because of our sponsors, these are companies that I trust, that we vet carefully, that we use in clinical practice, that I use personally. Because of them, everything associated with this podcast is free. If you haven't done so, I suggest you head over to DrKF to the podcast page where you can access the full transcript for every single one of these 200 episodes. And along with that transcript, you'll get an episode summary. You can get the research citations and additional content that is pertinent to the episode. I myself return to the transcript page all the time to pull out a little snippet of information that I want to recall or access a citation. Or better yet, sign up for our newsletter, again, at drkfitzgerald.com, and every single podcast episode will drop in your email as soon as it's released. Thanks again. Thank you to our diamond level sponsors, Biotics Research, Rupa Health, and Integrative Therapeutics. For over 40 years, the foundation of Biotics Research has been innovation and quality. Their goals remain unchanged: innovative ideas, carefully researched concepts, and product development with advanced analytical and manufacturing techniques. Biotics nutritional products are of superior quality and effectiveness. They're available exclusively to healthcare providers. Find them at bioticsresearch.com. I also want to give a shout out to our friends over at Rupa Health. They make lab testing easy, fabulous, doable for you, the clinician, and for you, the patient. Consider using Rupa as your super, super, super smart solution to all things laboratory testing. Visit them at rupahealth.com. For over 35 years, patients and clinicians have trusted Integrative Therapeutics for their dedication to quality, potency, and accuracy, and for bringing us exclusive products backed by science. From sourcing of premium raw materials to their meticulous manufacturing processes, they prioritize consistency, efficacy, and safety because our patients deserve nothing less. Find them at integrativepro.com. That's integrativepro.com. Thanks to our gold sponsors, Timeline, Mira, and OneSkin. Timeline, fueling cellular energy for a lifetime of healthy aging. Find them at timelinenutrition.com. Mira, the most trusted hormone monitor. Find them at miracare.com. And OneSkin, skin age reversal technology. Find them at oneskin.co. Hi, everybody. Welcome to New Frontiers in Functional Medicine, where I am interviewing the best minds in functional medicine. And of course, today is no exception. If you're with me on video, you can see I'm sitting next to really one of the premier scientists in the US times decades. Let me give you his background, and we're going to jump right in. Dr. Barry Sears is a leading medical researcher. He's the author of more than 50 scientific publications. He holds 14 U.S. patents in diverse areas, including IV drug delivery technology for cancer treatment, cardiovascular disease treatment, and the reduction of insulin resistance. He also has academic appointments at the University of Miami Medical School, Arizona State University, and the University of Cartagena in Colombia. Dr. Barry Sears, welcome to New Frontiers.
Thank you very much.
So we had the pleasure of connecting in 2023 at a conference in Mexico City. That was a lot of fun. And we had a exciting dinner. You know, there was a handful of us there, and I I think I was just really pinging you with questions, and it was clear I wanted to, get you on the podcast and continue that. So Dr. Barry Sears, for anybody who doesn't know, is authored the Zone book, the Zone diet book, back in the 1990s. It was a massive New York Times bestseller. It was really, I think, probably one of the first massive diet. I don't know. You'll know better than I do, but it just seems like it was one of the first books that sort of just set off this trend of people considering nutrition. I remember seeing it in my house, when I was growing up. It was there. It was a fixture. I don't know if, yeah, and there it was. But so I want to talk about that, about your movement into that. So your biochemistry background. I know you worked on drug delivery, but then you transitioned into nutrition. You really focused on fatty acids as a big piece of it. I know you brought fish oil to the minds of many, I think. And the importance of it. And then I just want to dive into, what you're up to today, and some of the really compelling conversation we had at dinner. So give us your backstory and, how you got to creating the Zone. And how life-changing it was, because it was such a massive book.
Well, again, my background, as you correctly point out, had nothing to do with nutrition. It had everything to do with cancer drug delivery and how to deliver cancer drugs more effectively. So in the early 1980s, I was basically one of the leaders in that area of encapsulating cancer drugs to small nanotechnology platforms and basically delivering them with greater efficacy. But my whole career changed in 1982 when the Nobel Prize in Medicine was awarded for understanding how a group of hormones called eicosanoids, basically caused inflammation. And I said, well, that's a much bigger field, because every disease state, the underlying cause is unresolved inflammation. So I immediately made a transition from cancer drug delivery into basically looking at how to manipulate these hormones, not by a drug, but by the diet, essentially using diet as a very powerful drug to manipulate the levels of these inflammatory hormones. And that led me into a great journey into basically how diet really controls the metabolism of every one of our 30 trillion cells in the body.
That's fascinating. So just give the listeners just a little bit of a background on eicosanoids. We're going to be familiar with that. I mean, there's a lot of clinicians listening, so they're certainly going to have some background. But what was identified in 1982? What was characterized?
What was characterized was the actual structures of the compounds that cause pain. Ouch, it hurts. Well, we have to have some inflammation, otherwise we'd be defenseless against microbial infection, or basically our injuries would never heal. But though we had to turn on inflammation, we also had to turn it off. And that part only came more apparent in really the beginning of the 21st century with another group of hormones called resolvins that turn off inflammation. So the idea of, we talk about a zone, it is, yes, like a therapeutic zone for a drug. If you give too little of the drug, it doesn't work. If you give too much of the drug, it's toxic. The same is true of our metabolism, except the stakes are much higher. That our metabolism is highly balanced in terms of checks and balances, especially in terms of inflammation. So basically, it's not saying I want a drug, which drugs are more like light switches. They turn the light on or off. Pretty simple. My grandson can do that. But metabolism's more complex. It's this dynamic interplay. It's more like a sound engineer in a recording studio, moving the buttons until you get just the right sound and maintain that in a day-to-day equilibrium.
And so that was your epiphany that prompted the creation of the Zone, and the name of the Zone has to do with finding that therapeutic sweet spot with nutrition.
Exactly. When I first wrote the book, my editor said, what do you want to call the book? I said, let's call it the Therapeutic Zone. She said, this is the dumbest idea I've ever heard. She crossed out the word therapeutic and said, we'll call it the Zone, and we hope we can sell a few copies. No one ever had anticipated the response it got. So I was as surprised as anyone.
That's amazing. And so eicosanoids, the structure was characterized. That's just so fascinating. It's so fascinating to me because, I'm in the world now where we're characterizing resolvins. And were they taught, was it gaining traction before you that the pain derived, the pro-inflammatory eicosanoids are coming from arachidonic? Or, I mean, you were part of you put that idea on the map that we had this massively skewed ratio. I mean, that was part of your work. I mean, talk about that. That's so fundamental to the fabric of anyone practicing functional medicine, integrative medicine. I mean, it's so fundamental to how we think about our patient cases, switching the polyunsaturated ratio. And here you were kind of laying the groundwork for that.
Well, and because again, we talk about the building blocks, of the eicosanoids that cause inflammation, and the building blocks of the resolvins that turn off inflammation are fatty acids. They're essential fatty acids. They cannot be made by the body. They must be made in the diet. But again, we're talking about a dynamic relationship. I had to have some to turn on inflammation, but they have to be balanced by those turning off. And what was apparent to me some 40 years ago, that the changes, we were getting a greater input in our diet of the building blocks for inflammatory eicosanoids, at the same time seeing a dramatic dropping off of the omega-3 fatty acids in our diet, which are necessary to make the resolvins. Now, it was a little more complex than that, because now we bring in the diet. What controls the underlying control besides the absolute amounts? It's a balance of two other hormones in the body. One is called glucagon, and the other is called insulin. That's controlled by the ratio of protein to carbohydrate in the diet. So now you say, oh my God, I've got to think not about the balance of omega-6 to omega-3, but the balance of protein to carbohydrate to keep these eicosanoids in that zone and resolvins in the zone. So basically, now the body can perform at peak efficiency.
So just thinking about that, if we and linking carbohydrate protein over to eicosanoid production. I mean, if you're consuming a lot of carbs and you're cranking out insulin actually turns on production of the fatty acid synthase enzymes, and you start to produce a bunch of arachidonic acid.
That's right. Basically, the worst of all possible worlds.
Yeah.
And so basically we had those two different trends coming together at the same time in the 1980s. It became apparent, but now we can see, looking back some 40 years, and saying that was a very, very bad combination. And we're paying the price for it. Yes, we see inflammatory conditions like obesity. Obesity is an inflammatory condition, but every chronic disease is an inflammatory condition. Yeah. It says we just have not achieved that right balance between those two components of basically turning on and turning off inflammation. But that being said, once you can, you usher in a whole new era of medicine. Now you're basically saying, let's go back to the soundboard where we get that right sound and then use the least amount of drugs if need be. So rather than basically become now a pharmaceutical driven healthcare system, we want to get back to basically looking at the bigger picture, saying you cannot dissociate the diet from basically metabolism. Metabolism is incredibly complex, and this is why most medical students fall asleep in those lectures. They say, it's too complex, I'm falling asleep. It's just, it is complex, but if you can break that complexity, then you have basically the keys to a new pathway of how to practice medicine in the 21st century.
What is the basic zone diet? What are the principles of it?
Well, I stole it all from your grandmother. So the basic principles are saying, first of all, you need some protein at each meal. Okay, how much? Well, you need about 30 grams of protein at each meal. Why? To stop hunger. What's the hottest drug right now? Wegovy, Ozempic. How do they stop hunger? Basically, they inject hormones that go to the brain to say stop hunger. But that system has already been in our body for hundreds of millions of years. It's the protein in our diet at each meal that can basically activate those signals to go to the brain and say, stop eating. Now, this is important because the most powerful drug we have known in the medical science is called calorie restriction. It works. It works all the time. And why? Because if you basically restrict calories without restricting nutrition, you can activate the master switch in every one of your 30 trillion cells. It's called AMPK. And once you activate AMPK, you now have the master switch under your control that can turn on and turn off inflammation. Okay, so getting 30 grams of protein, that's the amount of protein you can fit in the palm of your hand. That's what every dietitian says. Well, should I take more? No, because now you affect other gene transcription factors that basically turn on the inflammation. Should I take less? No, you won't get satiety. You'll always be hungry. And now, okay, I got the protein. What about the carbohydrate?
You're tweaking that though for body habitus, I would imagine. It's not a
there's-
one size fits all.
Two reasons for protein needs. One, to stop hunger. That seems to be invariant. Invariant for male, female, elite athlete, non-elite athlete. Now, there's a second aspect. How much protein do I need to maintain my lean body mass? That's dependent on your physical activity level and your lean body mass. That can be higher. But for the vast majority of us, people like you and I, who are not elite athletes, 30 grams of protein is about all we need.
So you're looking at maybe 90 grams a day then, if you're thinking three
Exactly.
meals, is that where you're tagging? Okay. So a relatively robust amount of protein.
Robust, except the fact is, like I said, every dietitian says, yeah, eat about the amount of protein palm of your hand. No more, no less. But you have to balance that with carbohydrates. Now, which ones and how much? Well, now we get into basically the Miller Lite time, where we have people arguing and saying, oh, carbs make you fat. No, fat makes you fat. So this is like the old Miller Lite commercials. Less filling, tastes great. Less saying, guys, you missed the point. You need some carbs to balance off the protein. How much? About 40 grams. Okay, which ones? The ones your grandmother told you to eat. Vegetables. You can't leave the table till you eat all your vegetables. Why? Two reasons. One, it's hard to overconsume vegetables. Two, they contain other things such as fermentable fiber and polyphenols. And so basically what you're doing, you're getting a good chunk of these extra nutrients that help fine-tune that metabolism. So check one, how much protein in each meal? 30 grams. How much carbohydrate? 40 grams. Now, how much fat? A dash. What's a dash? A small amount. It might be a tablespoon of olive oil, especially extra virgin olive oil. Could be basically 14 almonds or 2 tablespoons of guacamole. Now what you've done, you've constructed a drug for the next 5 hours that will keep your metabolism under control. The secret is repeat it every 5 hours the rest of your life. And people say, oh, I'd rather take a drug. I say, okay, I gave you an opportunity. But the fact is, you're looking at a drug that only basically has a small impact on metabolism versus a dietary program that has a major impact.
And why are you limiting carbs to vegetables, and what kind of vegetables?
Well, first of all,
I mean, you explained the polyphenol piece and the fermentable fibers. So yeah, put a pin in that, but just, where are you at with carbs as a broad category?
as a broad category, they think that which ones are, of all the carbs, the vegetables are the best. Okay, followed by the fruits. It's easier to overconsume fruits, and they contain a lot more simple sugar. Then you have the grains. Well, the grains are going to speed flush of the body with carbohydrates quickly, and that will increase the hormone insulin. And then you have got the worst of the worst, the white carbohydrates. They have no polyphenols. That's why they're white. And they just rush in the bloodstream, lickety split, and that pumps out insulin that basically disturbs the whole aspect of our metabolism. We call it insulin resistance. Turns out it's a little more complex than that, but it is basically looking to find an appropriate mixture that you can go through life on a day-by-day basis. Now, does it work? Well, yeah. Let's look at insulin resistance. the primary cause of most inflammatory diseases. Of how long does it take to reduce insulin resistance following this type of a program? The data is pretty clear. 4 days. I said, well, geez, in 4 days, if I eat like this, I've cleared up the body. Say, no, 4 days, that's you bring it down, but to keep it down, you got to follow it the rest of your life. And so who'd be the group of people most applicable to basically reducing insulin resistance? Diabetics. And our studies at Harvard demonstrated that within 3 months following this type of program, the diabetics went from basically being diabetic to non-diabetic.
And these are obviously type 2 diabetics.
Yes. Now, what happened after they stopped giving them the dietary advice? Human nature comes back, and of course, the levels went right back up again. But it's saying if you're willing to treat food like a drug, it doesn't have to taste like a drug, but basically understanding the biochemical consequences, you've got a very powerful way to basically orchestrate your metabolism, which is the key to maintaining a longer health span, which is defined as longevity minus years of disease loss due to chronic disability.
You, you're recommending a relatively modest amount of fatty acids, and you specifically say olive oil being a monounsaturated fatty acid. It's not going to increase the omega-3s. It's not going to increase the omega-6s. So yeah. Mm-hmm.
So it's neuter. Now from the standpoint of the fine tuning, like the soundboard, now I say, okay, I want to add more omega-3 fatty acids. How much? Do you guess? No, you test. You can test your blood using a finger stick test to say, am I taking enough omega-3 fatty acids? So you begin to now titrate your blood because you're unique to everyone else. So you get the ratio of arachidonic acid to EPA in an appropriate zone. Again, we need some inflammation, but not too much.
Right.
And likewise, the polyphenols. I ate an apple today. Is that enough polyphenols? No. So how do you know if you're taking enough polyphenols? Another simple blood test, glycosylated hemoglobin. Because the polyphenols, they activate a gene transcription factor known as NRF2 that basically reduces oxidative stress and reduces the impact on basically glycosylated hemoglobin. So now the only two supplements you really need are basically polyphenols and omega-3 fatty acids, and you can fine tune those by a blood test.
Okay, so I want to get you've been great at sending me papers. In fact, and folks, as usual, we'll pack our show notes full of these papers if you go over to the website, drkfitzgerald.com. So all the transcription and Barry's papers. He's been really prolific, and you're good at sending me, anything that's relevant in the conversation we might be having online. I appreciate that. So looking at this polyphenol to A1C connection, any publication I can put on my website, I'd be interested to do, and bridged by NERF too. What's an A1C level that what's your range for a good A1C?
Well, the range saying you're okay. They say anything under 5.6, you're okay. You're not well, but you're okay. So my definition of being well, you want to keep the A1C between 4.9, 5.1%.
Okay. And are you looking at, just out of curiosity, any other variables? Like what do you think about fasting insulin levels, or are you really hanging your hat on A1C?
Your ultimate aspect, are you controlling insulin resistance? That's why I always like to use HOMA-IR. This is a coming from both the fasting glucose and fasting insulin. If you put in a small equation, out comes a number. If it's less than 1, you have no insulin resistance. It means you're well. That's about 1% of Americans. Between 1 and 2, that might be normal, but you're not well, but you're not sick. Once it hits 2, you start to have insulin resistance. And now you have entered into a world of pain. The first consequences of increased insulin resistance, excess body fat, followed by diabetes. And once you have diabetes, you're now 4 times more likely to get heart disease and twice as likely to get Alzheimer's. Those aren't the only diseases. Virtually every chronic
Everything.
has a strong association with increased insulin resistance.
Well, let me
Why?
just, yeah,
Go
go
ahead.
ahead. Well, okay, so let me just say this. There's a podcast I just talked to Nathan Price, who's a fascinating scientist at the Institute for Systems Biology, and they published a really cool paper in 2019 looking at biological age and some of the chronic conditions we see, commonly. And, diabetes was the #1 age accelerant. And so age being the biggest risk factor for all the chronic diseases, I mean, you can see how it absolutely lights the fire, and this whole inflammation phenomena that you've been talking about for many, many years, it's right there.
And it's been there, but now finding a system that people in the real world can follow. And basically guidelines. How do I know what I'm doing? Well, the tests I've talked about are very simple tests. But they basically give you guidelines, like buoys give you a navigational channel. As long as you stay within the channel, life's going to be okay. Once you get outside that channel, basically you're on uncharted waters. So we are looking at basically insulin resistance as a marker, a surrogate marker of a disrupted metabolism. Now, that is all due to basically inactivity of AMPK. We can't measure AMPK, but we can measure insulin resistance. So we have now a watch guard say, okay, whatever disease state I have, my #1 goal is to reduce insulin resistance. And the primary drug there that has an unlimited therapeutic index is called food.
Yeah, that's right. Or fasting. And I want to return to fasting, but before we do, I just want to get the optimal EPA AA ratio. And I want to let listeners know, clinicians out there who are looking routinely at fatty acids, we can get big fatty acid panels covered by insurance now. I mean, we're looking at very detailed, omega-3s, omega-6s, omega-9s, saturates, et cetera. We just have access to awesome data these days. And every company, every laboratory analyzing fatty acids includes your ratio. You put this on the map. And so I want to give credit where credit is due. And that's the AA EPA ratio. So speak about what's optimal for you. Reference ranges change with labs. So what's the specimen and what's optimal? And, I just find it really kind of cool. Like this was what you put on the map many years ago.
Well, the optimal ratio, at least from our clinical trials, is between 1.5 and 3. The higher the ratio, the more inflamed you are. The average American is about 20. To my last
So
knowledge,
3
20.
AA or 1.5 AA to EPA. So you're going to have a little more arachidonic.
Yes, you need some.
Always. Yeah.
Oh.
And you do need some. Yeah.
But when you're up to 20, you've got too much excess, and now inflammation is spreading in every organ of the body. So all of our clinical trials that we do, we always titrate to that goal.
Mhm.
Now, how much does a person need? It depends. And that's why you get into the personalization of functional medicine. Say, how much do I need? Say, let's check the blood. The blood will tell you. Likewise, how many polyphenols do I need? Let's check the blood. The A1C is a pretty good, easy marker that say, do I need more polyphenols? Highly likely, do I need less? And so now you have as really kind of navigational stabilizers along with the diet. Say, I can now fine tune and personalize a program for the individual. One size does not fit all.
Going back to the original conversation, obviously carbs, insulin resistance will push arachidonic acid endogenous synthesis. And so that would be something you would use to drop that AA like a stone that doesn't require actually supplementing with fatty acids. Bringing supplementation in, I mean, are you using flax? Are you using, fish oil? Are you using fatty fish? I mean, what are you doing to raise omega-3s?
Well, I use basically purified, omega-3 concentrates. One, they're purified. Most fish are not, and they basically carry a fair amount of toxins. Uh, in terms of flax, it has no benefits whatsoever because its transformation into the longer chain omega-3 fatty acids is incredibly slow and inefficient. So it's not a very good source of basically modulating that balance of insulin, but of resolvins and eicosanoids.
You're not impressed by the lignin content and the fiber?
Oh, the fiber is fine. That's great because again, the fiber is again what our microbes need to survive. Basically, they break down the fiber, the fermentable fiber, into small, short chain fatty acids, which not only are a fuel source for the cells in the gut, but more importantly, they act as signaling agents. So again, that's why fiber is so important, especially fermentable fiber. So from that standpoint, flaxseed is a great source of fiber. It's the poor source of omega-3 fatty acids that can affect the balance of eicosanoids to resolvins.
So, okay, so supplementation of a purified EPA DHA. And what kind of dosage are you looking at in general?
Again, it depends on the disease state. For the
Yeah.
average person who doesn't have any chronic disease, probably 2.5 grams of omega-3 fatty acids per day.
Strictly EPA to DHA?
No,
all
yeah,
of them?
The combination. I
Okay.
always a 2-to-1 ratio. Now, that seems like a lot since the average American takes in about 125 milligrams. But that's exactly what every child in America had to take 4 generations ago when their mother gave them a tablespoon of cod liver oil. World's most disgusting food, still is, but that contained about 2.5 grams of omega-3 fatty acids. So again, we have now, but what if you have a disease that has higher levels of inflammation, especially in the brain, like severe brain trauma? Those we've gone higher, about 16 grams per day.
Yeah,
So it depends on where the inflammation is located and the individual.
And folks, we'll post some of those case reports using really high dose omega-3s in traumatic brain injury. They're incredibly interesting. I mean, we could leapfrog here into talking about dementia, where there's some evidence that we don't deliver effectively in the brain, once the dementia is present. And so higher doses could be indicated there as well. And then, of course, I want to talk to you about some of the new omega-3 structures. So I'm going to put a pin in those two, but we'll circle back. But before we do that, I just want to talk about the caloric restriction piece, because you brought that up immediately. So there's the information from the nutrition that you've just outlined, but there's also caloric restriction as being, really one of our important tools, or time restricted eating, I guess we could also say.
This episode is supported by Practice Better, a leading all-in-one practice management platform. Most health and wellness professionals love what they do, but feel overwhelmed with time-consuming administrative tasks. With Practice Better, you can automate tasks like onboarding, scheduling, charting, nutrition planning, and billing to help you better focus on the parts of your practice you love. New Frontiers listeners get 20% off the first 4 months of any paid plan at practicebetter.io with code KF20. Visit the podcast page on drkarafitzgerald.com for more information.
As we go deeper into the world of longevity science, I want to introduce you to a company rewriting the rules of skincare. Founded by 4 PhDs in skin science, OneSkin has developed a peptide scientifically proven to address cellular aging. By targeting senescent cells, their OS01 peptide helps skin look, feel, and behave younger, visibly reducing lines and wrinkles and improving skin's texture and overall appearance. To learn more about their groundbreaking approach, visit oneskin.co. That's oneskin.co.
Well, again, it all comes down to 2 things. One, restricting calories, but without restricting nutrition. But people are always trying to basically find a new clever wrinkle, saying, I know if I eat in a certain window, that will do everything. Saying, not quite. Here's my take on calorie restriction. Eat your first meal as soon as you wake up. Eat your last meal before the sun goes down. Now, why is that? Because it's the change in the intensity of light that basically changes basically how our body works on a metabolic aspect. This is why studies are quite clear. There's no benefits of, quote, of intermittent fasting to continuous calorie restriction. None whatsoever. Second aspect, intermittent fasting.
Go ahead.
Intermittent
Yep.
fasting in the morning is a lot better than intermittent fasting later on the day. So again, you're looking to basically try to time your metabolism with the circadian rhythms driven by the intensity of the sunlight. And so that's why you had those 2 points when the sunlight intensity is changing the greatest in the morning and the evening. Those are 2 times the same. Those are my start and stop points. Now, if you live in Boston during the summer, say, great news, I can eat all day long. But then if you live in Boston during the winter, say, bad news, I can eat only a short period of time. Say, those are the rules. That's why a lot of people move down to Florida. You can basically eat longer periods of time, both summer and winter. But again, so intermittent fasting, and doesn't take into account the balance of protein, carbohydrate, and fat. It says just eat 2 meals a day, and basically that's it. What do you tend to do? You eat more calories in those 2 meals than you would in 3 meals, or more calorie per meal than if you had 3 meals. It's the amount of calories per meal that has the greatest effect on calorie restriction. But those calories still have to be balanced. So this would say, it's so hard. Can't you just make it easy? Say, it was easy, everyone could do it. It's not that hard, but basically it requires a little discipline.
Right. So if you're in Florida and you think, yay, I can, eat whenever, you're being really mindful of quantity. I mean, that's the
No,
break.
even in Florida, the sun does go down. So
Right.
so I said, okay, make sure that last bit of food has gotten into your mouth before the sun has gone down.
It's pretty interesting. I mean, there certainly are, studies really looking at circadian rhythm and dietary patterns these days. And yeah, that's fascinating that you, you realized that some time ago. Caloric restriction, like about how much do we want to be dropping? Like how much, what's caloric intake for, the average 70 kg per 150-pound person? I mean, what are we looking at for numbers here?
Well, we have now the Caloria studies, which basically are about $50 million of studies asking what happens when you give calorie restriction. Well, the first thing that calorie restriction, you're very compliant for about the first of 3
That's
weeks.
right. And that was a 25% restriction, the calories.
Eventually at 10%.
That's right.
Study.
Yeah.
But if you had that balance, remember that balance of protein, carbohydrate, and fat of 1,500 calories is actually a very hard meal of 1,500 calories per day is a lot of food. And so that because most of the carbohydrates are coming from non-starchy vegetables. So you're getting the greatest nutrient amount in the least caloric amount, balanced with now the protein to stop hunger. You can't do calorie restriction if you're always hungry. It's not going to work. Mm-hmm. And you also have to basically have a great source of micronutrients. You're going to get those primarily from the vegetables. So you're eating a lot of vegetables, just like your grandmother told you.
Right. Fat is very satiating as well.
Exactly. And because of the fiber content and basically the length of time, because the signals of the satiety signals are not evenly distributed through your gut. They're primarily in the lower part of the intestine, the ileum, and the colon. And those satiety signals, the longer you can maintain them, the less hungry you are. That's the secret of Wegovy. I'm not hungry. Unfortunately, with Wegovy, you're also malnourished because you're not hungry, you're not eating enough protein. So about 40% of the weight loss is lean body mass.
Yeah, they have shown that. Yeah.
I mean, it could be heart, liver, kidney, brain. These are the things you don't want to lose.
Right. I mean, it could be effective if it was, combined with intelligent eating. But I even see, I see colleagues, in the broader sort of nutritional science space, maybe the scientific space, the longevity space, very adherent to, profound caloric restriction or time restricted eating windows where they're having one meal a day. There's the one meal a day crew. And to me, that just strikes me as very difficult to get nutrients from food if you're going to do one meal a day. And I think it just sets individuals up for malnutrition. I mean, we certainly see people coming into our clinical practice who have adopted some of these really restrictive patterns that are popular now, having some fallout. And then, we see sort of disordered eating arise because, the body and the psyche is going to rebel with these for some individuals. Some individuals have a lot of discipline, but we can definitely see, malnutrition start to present itself with some of these really restrictive patterns.
And I would rather say malnutrition, I'd say basically long-term metabolic disturbances. And so again, that people are always trying to think, I've discovered something that nobody else has ever seen before, saying, hey, get real. The fact is, the verities of basically medicine and nutrition have been pretty consistent since the beginnings of recorded history. We just have now the science to go deeper into metabolism and say, oh my God, now I know how important it is. Because the key factor you're looking is to activate one factor is AMPK. This is kind of your master regulator. And the most powerful tool we have in medical science to do that is calorie restriction.
Yeah. Okay, that's great. That's awesome. We'll circle back and talk a little bit about AMPK. First, thoughts on dimension, higher dose fatty acids to, just assist in crossing the blood-brain barrier, because there's a real deficit, I think.
Well, there is
a deficit of synthesis, of local synthesis. Yeah, go ahead.
This is why the ApoE4 allele is so important in terms of predicting who's likely to get Alzheimer's, because that allele is also connected with the transporter that basically moves the fatty acids from the blood into the brain. But the people who have that allele, it's only maybe 1 to 2% of the population. So here we have to go back and say, do we have a marker of Alzheimer's much earlier that you're likely to have Alzheimer's? Well, the answer is, before I say, where's my car keys? The answer is the levels of insulin resistance.
Sure.
So it's okay, my first sign, my HOMA-IR is no longer 1. I want to start paying closer attention to my diet because it's really insulin resistance that is really the underlying cause, not only of Alzheimer's, but also Parkinson's. Both of those diseases can be viewed as the batteries are running down in different parts of the brain. It's in the frontal cortex in Alzheimer's. It's in the locomotion areas back in the for Parkinson's. And basically, what controls the production of energy in the brain? Mitochondria. And what controls mitochondria? AMPK. So again, all roads begin to converge back. To say I can look at now things like Alzheimer's or Parkinson's as basically the batteries are running down. And so what can I do to get those batteries working better? Well, I have to activate AMPK. And what's my best easily seen blood marker? The levels of insulin resistance. So basically, we keep on coming back to the same aspect that say the body is giving us simple signals from the blood that allow us to adjust our diet for our particular biochemistry and our particular philosophy. I don't care where the protein comes from. It can come from non-animal sources. Just make sure you get 30 grams of protein at every meal. And balance it off with the carbohydrates, the vegetables being the best, because it's hard to overconsume them. But fruits are fine too, just be a little on the careful side, and a dash of fat. And then basically look at your blood test again to say, do I need extra supplemental omega-3 fatty acids or extra supplemental polyphenols? And call it a day.
What would those supplemental polyphenols be?
Well, there's 8,000 polyphenols. So you say, oh my God, I have got to go to GNC every 4 hours. No, it turns out most polyphenols do not get in the blood. Now, they are broken down by microbes in the gut to smaller phenolic fragments that can get into the blood, but they're not as effective in changing the levels of AMPK as a full polyphenol. Now, we can ask which polyphenols actually get in the blood. Now we go from 8,000 to about 1. There's one subclass of polyphenols. They're called delphinidines. And these are the most water-soluble of polyphenols. Where do you find these? Red wine. Great news. I can drink my way to immortality. Unfortunately, to get enough of delphinidines, you have to drink about probably 4 bottles of red wine per day. So you can see little problems down the road with that strategy. So again, there are polyphenols, and we also know that the delphinidines seem to be the most powerful in basically destroying what are called zombie cells. So if we can get those into the blood, then basically without drinking the 4 bottles of red wine per day, then basically we have another way of basically adding on to that fine-tuning mechanism to basically activate AMPK in every organ in our body.
So why the attachment to absorbing an intact polyphenol? I mean, the microbiome transforms them into these beautiful postbiotics that have been demonstrated to be potently active.
Well, potently is always a kind of I always use human data, which is always a kind of a short amount.
Well, I'm mentally referencing human data here in postbiotic. I mean, we evolved.
The more complex the polyphenol, the more it can basically interact, in this case, with the sirtuins that now affect enough upstream regulator AMPK, turn on that. So as you get the smaller phenolic fragments, they're not nearly as effective as a full-fledged polyphenol if, that's a big if it get into the blood intact. And this is shown in a study in a decade ago, looking at elderly Tuscans still eating the old Mediterranean diet. And the researcher said, now we can take these older Tuscans and look at one parameter, mortality, and say, we would expect the more polyphenols they consume, the longer they will live. They did the study and did all the data analysis. There was no relation, none whatsoever, between the levels of polyphenols consumed and their time of death. They said, this makes no sense. So they went back and said, wait a minute, the polyphenols probably have to get into the blood. They're hard to measure in the blood, but they have to leave the blood, usually by the urine. Right. So they took the urine samples, and now they found exactly what they're looking for. Those who had the most polyphenol fragments in the urine lived 31% longer. So again, that's why you had to get, it's really the complexity of the phenolic aspect acting as an allosteric activator of the sirtuins, which now start a whole metabolic process that activates AMPK.
Okay, so that makes absolute sense. And there's a number of studies looking at, you know, the postbiotic products in urine and associating those with gene change, you know, looking at epigenetics now. So that's a thing. What I'm going to do, I want you to, you know, send me these delphinidine papers, and so we can check it out, and the people, you know, listening today who want to dive in can go to the website and read some of the research that you're referencing. I mean, I think we're in agreement here when you talk about the Tuscans having high evidence of polyphenol consumption looking at urine. I think that's, you know, definitely, you know, that's in alignment with my thinking as well. But I want to jump over to what we were talking about at dinner, which was really incredibly compelling to me. I'm always paying attention to the science on omega-3 fatty acids. I teach on this. I have for the last, well, you know, I'll be teaching shortly to the Institute for Functional Medicine for the last 12 years now on omega-3 fatty acids. And I'm paying attention to these new pharma studies coming out. I mean, I remember when we were waiting on them, and, you know, now we've got some data, and the data is decidedly mixed. I would say that since they do these composite endpoints where they compile all, you know, the events they want to look at into one bundle, they often don't see anything significant. And I think that that's the fault of trying to frame basically a nutrition study through the lens of pharma. So when you tease out the endpoints, all of the studies, without exception, show some degree of benefit with regard to heart disease, stroke, et cetera. There's just, you can tease these out, and I go through those data, every year, and there's always something new, sometimes pro, sometimes con, but there's always something hot to talk about in the omega-3 space. It's pretty funny. But one of the things that's been interesting and sort of given pause to the community is this notice that some of these larger trials, these pharma trials, show either a trend towards AFib or, not quite at significance or, frank significance. So the strength trial was one of them, using a carboxylic acid EPA DHA combination at 4 grams. That trial was actually halted. When they went back and did an analysis of the data, again, they did show some benefit, but they stopped it, short a pretty significant chunk of time. And there was a little bit of an increased risk of AFib. Same with the Reduce It. That was a non-significant trend. The OMEMI study showed it a significant trend in a certain demographic. But the Ascend and the Vital, which were about 1 gram each, the Ascend and the Vital were just under 1 gram. Vital, looking at healthy individuals, no increased risk in that population. But those other larger trials where they were using high dose omega-3s of, pharma omega-3s showed in some cases a trend towards AFib. I do want to say, for anybody listening to this, that the actual risk, when you drill down, it was reported as 37% increase when they did this meta-analysis, which will make everybody freak out. But when you look at the risk within, how they obtain that percentage, I think overall it was only about 2.5% developed AFib, and just a micro amount of those were associated with the omega-3s. But when you and I were talking, you just really had some interesting thoughts. Then I wanted you to just, share your thoughts on this finding. And of course, we also know from earlier studies, so let me layer this in, that omega-3s are protective against AFib. So this came as a surprise to the community for sure.
Well, let's start with the last question you posed. It turns out, if you look at now large-scale studies, the higher the levels of omega-3 fatty acids in the blood, the less AFib you have. I say, well, that says omega-3 fatty acids are good for you. Now the studies you mentioned, basically, as you correctly point out, they're drug studies. Drug companies they know nothing about omega-3 fatty acids, but they do know something about marketing. I want to get the highest concentration and say, I'm the winner. So when you looked at the strength trial, first of all, it was using the free fatty acids. Anybody who knows anything about omega-3 fatty acids knows that free fatty acids are incredibly unstable. They cause oxidative stress. So again, that to say, but I have a patent on it, a patent on a bad form of omega-3 fatty acids. The other studies, like the Reduce It, they said, we're going to basically just say it's all about EPA. So we'll keep on cranking out our molecular distillation to get higher and higher and higher concentrations and say, we're number one. Look how high our EPA levels are. The trouble is that the longer you put these omega-3 fatty acids under this distillation process, you get isomerization of the double bonds that now turn nutrients into anti-nutrients. And so you either have the wrong form that's guaranteed to cause massive oxidative stress, or you've isomerized the fatty acids so that now the pharmaceutical product is causing basically really an anti-nutrient effect as opposed to a pro-nutrient effect. So again, this is one of the aspects of people have to kind of look, and I say the drug companies do not make these. They don't have no knowledge. They buy the stuff and say, fine, we'll put our name on it, call it a day. But the fact is, this is a problem as you go to higher concentrations for marketing purposes. that you'll get more isomerization. Now, that being said, saying, I have to go back to taking cod liver oil? No, but there are new technologies that can basically concentrate up omega-3 fatty acids without the heat that causes the isomerization. And this is called supercritical fluid technology. And when you're using supercritical fluid technology, it's more expensive. Basically, the temperature never rises much above 50 degrees centigrade. In molecular distillation, it's about 200 degrees centigrade. So bad things happen at high temperatures. But then that goes back to saying, now looking at the population studies, the higher levels of omega-3 fatty acids you have, the less AFib you have.
So yeah, first of all, looking at isomerization, I mean, it makes sense to me. And when we had this conversation in 2023, I came home from that Mexico City conference, and I had a follow-up chat with Dr. Jeff Bland, the father of functional medicine, and he agreed that this change in structure could certainly be happening, and so there could be byproducts present in some of these very high doses that could be doing untoward things. However, they certainly haven't been identified, and I did due diligence in attempting to find data on this, and I didn't find anything. Certainly, we've looked at, there have been publications looking at the oxidized fatty acids. Those have been published, but those tend to be, those are supplement companies. Those are OTC supplement companies, where you can see that there's a broad range of quality, so you can certainly see oxidation there. But you're implicating pharma. I mean, you're saying these products where there's all sorts of controls going into developing them, are producing these byproduct compounds that are really largely undetected and unstudied, and that these are driving the micro amount. So I still want to say that the incidence of EPA, DHA associated AFib in this in these larger studies is still very negligible, and we're still seeing benefit when we tease out those endpoints. But nonetheless, it's alarming to see it at all. And your suggestion is that's caused by yet to be identified compounds. Really, it's the process of making them that seems to have you convinced that they're there.
And it goes back to basically my early work about 30 years ago, working with them, the leaders in the field of manufacturing. They had developed what is called a smell test. That they could basically take the GCs, they say, smell test, what kind of science is this? You could essentially on using mass spec, you could basically not see any changes, but you could basically smell as they came through there dramatic impacts and say, whoa, what is that? There's almost nothing on the chromatogram, yet basically it was giving rise to great amounts of basically some type of interaction with the olfactory signals going to the brain. But this is arcane knowledge. All the early pioneers in fish oil and manufacturing, they're all dead. Their knowledge basically died with them. And so now you have people who have no knowledge of the manufacturing. Drug companies don't make this. They just buy from others and put it in their pill. Unlike when they make a drug, they're actually doing the chemical manufacturing. So there's really no inherent knowledge in the pharmaceutical venue about omega-3 fatty acids and their susceptibility to isomerization and oxidation. So again, we have the blind leading the blind, but you're quite right. The concept is really what's called number needed to treat. It's saying, show me what are the benefits. I'll use an example. Statins. If you've never had a heart attack and the doctor says, I want you to take statins for the rest of your life because you have high cholesterol, you want to ask the doctor, okay, doctor, what's the chances that I will not get a heart attack if I take statins at the rest of my life at this dose? And the answer is of 1 in 112. Now, when you go to Vegas and put all the money on 36, that's a better bet than 1 in 112. So the fact is, that's where you have to go. We have to take all the things you get from the pharma, from marketing, say a 38% difference. Say, no, tell me what's the needed to treat, and also what is the needed to harm. A good rule of thumb for any drug, the needed to treat should be 5 or less. I'll give you one example. Aspirin. If I have a really bad headache, I'll take a big boy aspirin. And what's the chances that I will treat my headache? Pretty good.
Mm-hmm.
Now, everything is context dependent. What if I take a baby aspirin to prevent a heart attack? What is my number needed to treat to prevent one heart attack by taking a baby aspirin? The answer is 3,360. So, well, it doesn't work. You're right. It doesn't work. A baby aspirin doesn't work for treating, preventing a heart attack. It does a great job. One of the best drugs known to mankind to stop a headache. So we have to kind of, look at between the lines of this relative risk versus the absolute risk, and then ask what's the number needed to treat that I will get a benefit for taking this drug. So again, there's as much basically misinformation coming out of the drug industry in their marketing as comes off the internet.
My exploration of this for myself and how I'm going to treat my patients, how I myself am going to approach fatty acids and, for my family and so forth, has been, just again, sort of the understanding that, food first is where it's at, that the structures delivered, in a whole food approach are those that we evolved with, that we understand, that are, to your point, most stable. You're talking about the supercritical process of developing a EPA DHA compound, and I think we're going to have to post on that. We'll need to understand a little bit more about it versus some of these structural changes to be able to get very high concentrations, and we're seeing these in a lot of products, I think, beyond big pharma. So whole food. First and foremost, I think there's a place for considering cod liver oil again. I mean, I don't know that we're going to take it in a tablespoon. Certain cod liver oil products have the resolvins, to your earlier point, present in them, and then you're talking about supercritical. But it certainly has given me pause, even as we see benefit. But to your point, it perhaps takes a lot to see that benefit. Anyway, this is a really interesting and potentially game-changing conversation, and how we approach the ubiquitously prescribed EPA and DHA.
Well, you're correct. It goes back to basically first principles. You are what you eat. You can't run from that. And so I say, so what we can do now, we couldn't do 20 years ago. We now have enough information on the mysteries of metabolism to make some pretty good assessments of basically what is our goal. Our goal is not to treat the symptoms of a disease. It's to maintain wellness. So how do we define wellness? I think a pretty good starting point is your levels of insulin resistance.
Mm-hmm.
So if you can keep insulin resistance low, keep that HOMA-IR less than 1, then you've got a pretty good chance of going through life without developing chronic disease at an earlier age. So again, how do you do that? Basically, you gotta restrict calories, but you need adequate protein, the right type of carbohydrates, a little fat, and you have to take a couple. But the more you do that, the less you have to supplement as a navigational aid. When you have a terrible diet, you have to put in massive amounts of supplements or drugs to counterbalance the underlying cause, a pro-inflammatory diet.
Yeah, that's right. And I think, and to your point, when they look at AFib risk in populations consuming omega-3s in a whole food diet, so not supplementing, there's a clear risk reduction in AFib in those with the highest adipose levels or blood levels. I mean, there's a clear risk reduction in the dietary consumption of omega-3 fatty acids in AFib, clear risk reduction.
And this comes to the aspect of, this pharma mentality saying, drugs are bad, but nutrients are good, and I'll put them in a capsule, saying, same mentality. You're looking for magic pills. So again, you really want to be looking at saying, okay, now that we understand metabolism to a greater extent, what are the dietary things which are under our responsibility, and supplements or drugs should be secondary.
Yeah, that's right.
Helpers, not the primary tools in the toolkit.
Yeah, and so it makes sense, we often look at the quantity of omega-3s present in circulation, but the ratio, I can see why you lean on the ratio, because it's, it's that information. So it's not necessarily, perhaps, it's not how much, but it's the relative amount. It's pretty fascinating.
It's really the context. Like you
Yeah.
need some inflammation, but not too much.
Yeah.
As we come back to that word zone over and over and over again. Your goal is to try to find that right zone using the food you eat to basically have your primary marker, insulin resistance, always low. And if you've done that, you're going to go through life pretty well.
Well, you're doing well. It was great to meet you. And I know part of your backstory is wanting to prevent, the ubiquitous cardiovascular disease that was present in your family.
Well, and so far I've done a pretty good job. Now, I've found out why I had that background. My whole family had a long background of early death from cardiovascular disease. But it turns out that for myself, my brother, we both have incredibly high levels of Lp(a), Guinness Book of World Record levels.
Yeah.
Now, you can't change that.
Yeah.
But what you can do, you can basically change how your body responds to that. So again, this explains a lot why we had the genetic history. My father was a world-class athlete. He died in his early 50s because we had a genetic problem that basically, say, bad break, but you can overcome it if you're willing to basically put in the effort and the work. And what's the benefit? A longer and better life.
Did you decide to layer medication into your approach, or are you using completely nutrition sort of zone-based approach?
Well, it's still high.
Yeah, right. No, absolutely. But people,
So what you're looking to do is say, okay, now we'll use nutrition. I call it metabolic engineering. Makes it a little classier. Metabolic engineering to decrease the negative side effects of a high level of Lp(a).
That's right. Yeah, we've got at least one blog on our website on Lp(a). We can link to you folks. Yeah, this would be a whole other conversation. Yeah, you can't. There's Lp(a) in half of my family as well, and I lost my grandfather to sudden cardiac death when he was 60. So I know that story, and yeah, it's incredibly difficult. You really need to address everything around the Lp(a) to render the Lp(a) a non-variable.
Or address the consequences if you have a high levels of Lp(a). And saying, okay, I can't fix this, but I can fix the consequences. So I say I can live with it.
Yeah. Yeah, I think it's an approach that makes sense to me. Well, listen, Dr. Sears, it was great to have you on New Frontiers today. I just want to thank you so much for joining me, and we'll have to do it again.
It was a lot of fun.
As always, thank you for listening to New Frontiers in Functional Medicine, where our sponsors help bring the very best minds in functional medicine. And of course, today is no exception. Not everybody can be a sponsor on my platform. I appreciate the good work, the relentless research, and the generous support from my friends at Rupa Health, Biotics, Integrative Therapeutics, Timeline, Mira, and OneSkin. These are brands I know and trust and use in my clinic and can confidently recommend to you. Please visit them online and let them know you learned about them on New Frontiers. And if it's not too much to ask, consider leaving a thumbs up and a kind review wherever you're listening to New Frontiers. Thanks.